Hello, I'm James Hopkisson. I'm one of the consultants here at TFP Nurture, and I've been working in the field of IVF and fertility for at least 30 years. We've been asked to answer some of the questions that have come in on our social media feed, and hopefully this will give you some information about fertility treatment, how it relates to you, and if you have further questions, please don't hesitate to get in contact with the team. The first question came in asking, after 2 failed rounds of IVF with endometriosis, what would you recommend going forward? It's always very difficult to answer questions where you don't have a full picture. And I would suggest that anybody worried about their fertility with endometriosis contacts an expert to go through what their treatment would mean to them. If you are using IVF, either because of a delay in trying to conceive or because there's been damage to the tubes which transport the egg to the uterus, then tailoring a treatment cycle is more to do with age, ovarian reserve tests, AMH and natural follicle count, than a specific pathology. When we look at endometriosis, it may affect how you respond to the fertility medication, and that's a determinant of your ovarian reserve. So we want to see what your ovarian reserve tests are so we can stimulate the ovaries optimally in an IVF program. We also want to have a look at how your embryos have developed in the laboratory. So getting information when you're sitting down for a review with a consultant is key. Having that information prior to a consultation makes for a better experience in the consultation itself. At TFP, we like to prepare before we meet couples to discuss the options with them. So having a full set of notes if you've had treatment and another IVF unit is important. Having some baseline tests like a natural follicle count scan, which assesses the number of follicles in the ovary and any other pathologies that may impact on your fertility treatment, implantation, stimulation, is very worthwhile. Having an up-to-date AMH level is also important because this will determine how we may stimulate your ovaries. Looking at the male side is also important because people with endometriosis may well have a partner who have problems with the sperm. About 50% of the couples that we see here at TFP will have a joint cause for subfertility, and where a male factor may be also present. So my advice when you're looking at repeated cycles of IVF is get as much information as possible so we can tailor a treatment to you as an individual, as a couple. We've been asked through social media about diet and what one should be eating and drinking after embryo transfer. My rule of thumb for everybody is have a balanced, healthy diet. Of course, you should continue taking your supplements, folic acid and vitamin D. Other supplements that may be useful for endometrial thickness, for egg and embryo quality, may have been advised prior to treatment, and you should continue those up until the point where it's recommended to stop. Some supplements, like melatonin, coenzyme Q10, may be stopped at embryo transfer. Others you can continue, especially if you're worried about endometrial thickness or implantation. When you're looking at diet, having a balanced, healthy diet is important, and many recommend a healthy Mediterranean diet. I don't think we can talk about diet and exercise without mentioning the new drugs, GLP-1 medication that many people are using to lose weight to get in for IVF and fertility treatment. When you're looking at the GLP drugs, Wegovy and Mounjaro, one should stop these medications before trying to conceive. The manufacturers of both drugs will recommend a washout period. For Wegovy, it's 2 months, for Mounjaro, a month. We've been asked through social media about AMH levels, and a question's come in saying, on AMH alone, what is the level that fertility treatment shouldn't be taken? This is quite a difficult question to answer because it does depend on what your expectations of fertility treatment are. AMH is a hormone, anti-Müllerian hormone, which guides us as to what your ovarian reserve is like. It tells us how many eggs you may produce in a stimulation cycle. So with a low AMH, you may only get 2, 3, 4 eggs. With a high AMH, much more. So we tailor treatment to the individual. When you're getting through treatment with low AMH levels, age is predominantly the factor which is most important, which will give us an idea of success rate. AMH on its own won't tell us how likely you are to conceive. It will tell us how many eggs you may get. So at TFP, we will sit and counsel and explain what we expect you will do in an IVF cycle in terms of the numbers of eggs that you may get. And alongside your age, we'll be better informed or be better able to inform you of what your likely success rates are going to be. To one person, a 5% success rate may be acceptable. To others, it may not. When you're looking at low AMH and response to the stimulation drugs in an IVF program, it isn't absolute, but it may impact on outcome in terms of the number of embryos that we create, the number of those fertilized eggs, embryos that get through to the day 5 stage. So it is individual, and I think it's very, very important to sit down with your gynecologist, with the fertility team, to discuss your hopes, your expectations of treatment, and how your own investigations and age impact on outcome. At TFP, we will see all patients and discuss what is right for them and try and individualize care. Some people will have a lower chance of success, but will want to move forward with treatment. It's looking at you as an individual, as a couple, to advise on the best form of treatment for you to enable you to have the family that you want. We've been asked through social media about PGT-A testing. PGT-A is a technique where we biopsy embryos and look to see if they are chromosomally normal. PGT-A stands for pre-implantation genetic testing for aneuploidy. So when you're looking at an embryo down the microscope, we can look and see how well it's developed over the 5 days that it's been in the laboratory. Those tests indicate quality, but will not tell us whether an embryo is genetically normal, what we call euploid. As you get older, the number of chromosomally abnormal embryos increase, aneuploidy. With PGT-A testing, we can test embryos to see if they are chromosomally normal. This decreases miscarriage rate. In some people, it will increase implantation, and overall will improve your chances of having a baby. When you're putting back a euploid, chromosomally normal embryo, there is still a chance of miscarriage. Studies have suggested this ranges between 5 and 10%. When you're looking at miscarriage across age groups, at 35, you've probably got about a 20 to 25% chance of miscarriage. When you get to 40, that can be as high as 40 to 50%. So by screening embryos, hopefully we shorten time to pregnancy, decrease miscarriage, and increase implantation. If you are interested in PGT-A, it will be something that will be discussed with you. If you are older, over 38, if you've had a number of miscarriages, or numbers of cycles where implantation hasn't occurred. In many centres, especially in the US, PGT-A is used far more frequently than in the UK. Recent studies performed in the UK at King's have shown that PGT-A may be beneficial in people from 35 on to 40 and above. Doing PGT-A, the embryology team will take away 4 or 5 cells from the day 5 or day 6 embryo. These will be sent off to the laboratory for genetic testing. These results take 3 to 4 weeks to come back to the laboratory, so it does mean that embryos have to be frozen. It's not something that is turned around within 1 or 2 days. If you are interested in PGT-A, it is worth talking to your team at a TFP clinic as to how it may benefit your IVF journey. We've been asked through social media a few questions. One of these is, does your clinic split fertilisation where you use donor and non-donor sperm? The answer is yes, if it's appropriate. We'll sit down with you and discuss the options for treatment. If somebody wishes to use their partner's sperm alongside donor sperm, we can do that. Obviously, we can't replace an embryo that is conceived with partner sperm alongside an embryo conceived with donor sperm. And we have to balance out what is going to be the most successful route of treatment for you. We do that with your wishes in mind, and tailoring treatment to you as an individual, as a couple, is crucial. We want people to make informed decisions about treatment, so we'll discuss all options that are available.
At TFP Fertility, we understand that every journey is unique, and we are committed to being by your side every step of the way. If you would like to discuss your personal situation, please visit tfpfertility.com or call us to book a consultation with our caring team today.